There have been significant advances this past year in molecular diagnostics and therapeutics in AML, which will be showcased this week during the European School of Haematology How to Diagnose and Treat Acute Leukaemia meeting. In this video, we'll take a look at what was discussed on this topic during the European School of Haematology International Conference on AML in October 2019.
There, over the last years, we have learned a lot. We know a lot about gene-gene interactions now and how they influence the outcome on treatment, for example. In the future, we will have to put a lot of effort also to better understand the epigenetic changes that underlie this disease, especially as very often epigenetic mutations are predisposing to leukemic transforming events. We also hope that if we integrate those two data layers, we can come up with new biomarkers that help us to better predict therapies to both demethylating agents, but also the new targeted therapies like tyrosine kinase inhibitors, IDH inhibitors, or also the more broad compounds such as hedgehog inhibitors or compounds restoring the apoptotic pathway such as venetoclax. And I think in the future, these new technologies would also enter the clinical routine, as they will allow us to capture all these molecular aberrations quickly. At the beginning, there new technologies, fourth generation sequencing technologies such as nanopore might change our daily clinical routine.
The implementation actually of next generation sequencing, because since we now need mutations not only in hotspots but really mutations that are located throughout the genes, we have to sequence the complete genes to really measure mutations present or absent in patient samples. And next generation sequencing is essential there.
We can now offer healthy individuals that we might be at risk based on specific blood tests to undergo a specific molecular testing, which is deep sequencing of targeted and specific genes. And based on the results of the sequencing methods, based on the results of the sequencing, we will be able to define high-risk populations based on several parameters. One of them is the type of mutation, so the specific type of mutation. The second is how many mutations a healthy individual carry. The third is how big is the size of the clone, or how many cells actually carry the mutations, and a few other parameters, and we take them all together into a mathematical model that can predict whether a healthy individual will have AML in the next 8 years. The issue that everyone asks is whether we can do anything with this knowledge. So let's say we know that someone is going to develop AML in the next 8 years. So we believe that clinical trials should be designed to actually target the individuals with specific mutations if there are targeted therapies like IDH1 and IDH2 inhibitors. So individuals carrying these mutations can be enrolled to preventive therapy, and the outcome shouldn't be the prevention itself, because that can take many years. We should monitor biomarkers like the size of the clone, and if it reduces under the treatment, that means that we might be either delaying or preventing the disease, which might be good enough.
Acute myeloid leukemia is a disease which undergoes dramatic and constant change and evolution, and that the old adage of just characterizing the disease molecularly diagnosis is now no longer appropriate, and really at each progression we need to recheck, reanalyze and reassess what the leukemia is looking like. And really the future, I think, will be to recognise that AML is an adaptable disease and our therapy has to adapt with it. So in light of these dramatic challenges, the question is, how do we therapeutically go forward? We have a number of new therapies which are showing great promise. However, none of these therapies on their own will necessarily be the complete answer or be curative. Our options are either to increase the intensity of the treatment, as an analogy using a bigger hammer. The alternative is to combine many therapies together, and the analogy would be to use many smaller hammers in combination. The third option is to perhaps recognise that AML is infinitely malleable, and that perhaps clonal evolution is almost an inevitable consequence of patients that are destined to relapse, and to perhaps use more surgically targeted hammers sequentially when the patient needs it.
the clinical use of FLT3 inhibitors, which is actually an area that's evolving quickly. There have been 2 new drugs approved for this indication in the last couple of years. Midostaurin was approved in combination with intensive chemotherapy for patients who are fit for curative approaches. And more recently, gilteritinib actually approved by the EMA during the course of this meeting, and it had previously been approved in the US and Japan for relapsed and refractory patients with FLT3 mutations. These patients historically have done very poorly with chemotherapy approaches alone, and so they've really needed improved outcomes through advances in treatment. And previously, really all we had was the ability to escalate chemotherapy or do bone marrow transplant, and nothing targeted had been approved. So it's exciting to have new drugs, and the drugs actually do improve survival is the exciting thing. In particular, midostaurin improves the cure rate for newly diagnosed patients with AML and really is now a worldwide standard of care for patients getting curative treatment approaches. And in the relapse refractory setting, really for the first time, there's a drug that's been approved that is a single agent oral, largely outpatient-based treatment of AML that has outperformed standard chemotherapy from a randomized phase 3 trial that I led that is not yet published, will be hopefully soon. The talk is centered on presenting the data behind that drug's development and how we're using those agents today. Moving forward, it's important to recognize that we don't know the relative merits of one FLT3 inhibitor versus the other in the same context, meaning that in frontline therapy, currently the standard is to use midostaurin, but that doesn't necessarily mean it's the optimal FLT3 inhibitor for a number of reasons. Gilteritinib is more potent, it's more selective, and yet there are reasons to think that the broad kinase inhibition might actually be an advantage in the frontline setting. So a head-to-head trial comparing gilteritinib versus midostaurin, and similar trial comparing another FLT3 inhibitor, crenolinib, versus midostaurin. These trials are up and underway, and from these kinds of trials we hope that we'll establish what are the best therapies. And lastly, I would mention that there's a third drug called quizartinib that's the most potent FLT3 inhibitor thus far that has gone through phase 3 development and also showed superior survival in the relapsed and refractory setting. That's not yet approved. Outside of Japan, it's approved in that country. It's undergoing regulatory evaluation in Europe, and a frontline study of quizartinib versus placebo has been completed in the context of intensive chemotherapy. We expect those results in about a year. So the field's moving rapidly.
Now we've got a variety of targeted agents for FLT3 on the market now, and I think the challenge in the future will be to understand how best to use them. And the reasons that we might combine certain agents to address emerging clinical resistance mechanisms. So one thing that we've known for a number of years is that it's very important to have an inhibitor that can address all potential drug resistance causing mutations within FLT3 itself. But now we have some inhibitors like that, including the recently FDA-approved drug gilteritinib. And as these better inhibitors or even pan-FLT3 inhibitors have come to the market, we've begun to see some off-target resistance mechanisms, such as activation of the RAS/MAP kinase pathway. There's also been a variety of other preclinical mechanisms identified that can cause resistance, such as stromal activation of cytokine signaling, upregulation of anti-apoptotics or PIM kinases. And there's actually a large number now of combination clinical trials that are currently accruing. These both include combination with high-intensity chemotherapy, low-intensity chemotherapy, and a variety of targeted agents. And I think the challenge for us will be to really understand how we can effectively utilize combinations, because after all, there's only so many drugs that we can give at any given time. Will these combinations be effective? Will they be tolerable? are there ways that we can sequence them in a way that creatively to make them more effective and potentially better tolerated by patients? And I think I'm going to challenge our field actually to think outside the box and see if there's a way beyond just combining drugs that we can potentially think about how we can creatively use new ways of giving drugs, such as giving one agent sequenced with another agent to knock off individual clones to deal with the emerging heterogeneity of resistance mechanisms that we see. And I hope for the next ASH annual meeting that we'll have more answers than just throwing a bunch of drugs in a box and handing them to a patient.